So, I think asking about, any new symptoms, are they just kind of feeling off in a way? As you mentioned to me, Paul, like in general, as internists, we have a pretty low threshold to order thyroid testing, mostly because we know what to do with it most of the time. Like we follow it or we treat it, and it's pretty well differentiated. It's not the most vague. It's not like an ANA where it could mean a million different things most of the time.
I think that's in keeping with some of the endocrine guidelines too. Is they don't recommend universal screening because we're not quite there yet, but because the prevalence is so high, you should have a low threshold to screen. And they have a fancy pants term for that I'm blanking on. But like it can cause so many symptoms, either hyper or hypothyroidism, that just if you think of it, you should probably just check for it, just because it is so prevalent. And like you say, we know what to do with it.
And every once in a while, you just get like a crazy TSH, and you're just like, whoa, okay, now we do have something here. Yeah. So you feel, it's good. It's good to have a test that we know what to do with, Paul. So yeah, the TSH, you can get a free T4 or you can get a T3, but you don't have to get that for everybody. It's just kind of based on what's happening with the TSH. And then we asked about calcitonin. It turns out there's really not a role for that anymore now that we have more sophisticated molecular tests that are going to help us like further differentiate before